All right. We're going to go ahead and start the next session now. I just want to thank everyone for engaging with our leaders in the community on the back tables, and hopefully those conversations can continue as the day goes along. I think I know I speak for Blake and the conference organizers that we're having a great time today, and I hope you all are as well. We're moving on to the next session, which is high yield topics in hepatology, and I will be speaking first. So as you heard earlier, I'm an assistant professor of medicine here at the University of Colorado. I'm also the director of our liver transplant outreach program, which I'm happy to talk more about with you during the breaks or at lunch, but essentially it includes both educational initiatives within our own community, but also establishing outreach clinics outside of the Denver area, such as up in Montana, down in New Mexico, and all throughout the state of Colorado as well. But for my talk today is not necessarily outreach related. I'm going to be talking about malnutrition and frailty in the setting of chronic liver disease, and specifically talking about a practical approach to that. We'll then have a talk after this about alcoholic hepatitis and liver transplant, and then a talk about what we can offer for the treatment of what used to be called NASH. And I won't steal Dr. Wieland's thunder on that. All right. So I have no disclosures for this talk. The learning objectives, number one, is to define the term frailty as it applies to patients with cirrhosis and recognize the many interrelated factors leading to that condition. Number two, recognize the social determinants of health that contribute to malnutrition and frailty in patients with cirrhosis. And number three, identify a practical approach to assessing frailty and also interventions targeted at identifying that condition and preventing worsening frailty as well. I'll start by sharing a photograph of Dr. Thomas Starzl, who many of you may know was the transplant surgeon here at the University of Colorado who performed the world's first successful liver transplant in 1967. That was when the campus was, well, this building certainly didn't exist, but the whole campus was at 9th and Colorado. And you can actually, if you can see his scrubs, says the University of Colorado Health Sciences. This is a photo to remind us of a couple of things. One, this was only in 1967. I know it's a black and white photo, but in the grand history of medicine, the management of chronic liver disease and liver transplantation is pretty new. And the discussion of the topic today, frailty, is even newer than that. Back in Dr. Starzl's day, assessing frailty was maybe the eyeball test that he would give from the door. Dr. Starzl, by the way, considered a pioneer of transplant, and obviously we're very proud that the first liver transplant successfully done in the world was done here. But he actually intended on becoming a priest. That's a fun fact for you. He was planning on going and becoming a priest. Actually, his mother was diagnosed with breast cancer when he was younger, and that caused him to change course and go into medicine and be the pioneer of transplant. So transplant evaluations take, at our campus, a couple of days, and it's an intensive process. And the goal of today's talk is not to talk about our transplant evaluation necessarily, but to highlight the fact that in addition to the surgical evaluation from Dr. Starzl's successors, a cardiac evaluation, lab testing, imaging, a psychiatric or psychological assessment, social work evaluation. A big part of this is their nutrition evaluation as well, assessing their nutritional status and patient education regarding that. There are guidelines by the AASLD, the American Association for the Study of Liver Diseases. This is our governing body, especially in North America, for guidelines related to the management of liver disease. Malnutrition, frailty, and sarcopenia in patients with cirrhosis. This is largely out of data from UCSF, but you can see that this was published just in 2021. It's one of our newest guidance documents, and I'll make references to this as we go along in our talk today. But I also want to just emphasize that you can refer to this anytime you like by just visiting the AASLD website and seeing their guidelines, which we always try to follow. So first of all, malnutrition, what is it? Well, it's a clinical syndrome. It results from an imbalance, and that can be either a deficiency or excess of nutrients that causes adverse effects on the body, size, composition, and function, and that leads to adverse clinical outcomes as well. I also want to emphasize at the start of this talk that malnutrition represents a spectrum of nutritional disorders. This isn't just referring to patients with low BMI necessarily, but across the entire range of body mass index from underweight to obese. And malnutrition itself leads to adverse physical effects, as we'll talk about at length, commonly manifested phenotypically as what we call frailty, or the term sarcopenia, which I'll discuss again. So in the setting of cirrhosis, first of all, cirrhosis is a catabolic chronic illness. It's accompanied oftentimes, for a variety of reasons, by reduced appetite that may be related to the fact that they have, a lot of these patients are decompensated. They have ascites. That ascites also masks muscle wasting. And then there's a misconception regarding protein intake. So we know that there's no need to limit protein intake for patients with chronic liver disease. These are just some caveats that I'm mentioning at the start. And malnutrition leads to poorer outcomes following liver transplant as well, especially with a BMI less than 18.5. This was studied nicely in a publication from 2015 from faculty members who formerly worked at this center, and showing that low rather than high body mass index confers an increased risk for post-liver transplant death. In fact, in this study, overweight and obese liver transplant recipients did not have an increased risk of death or graft loss, regardless of their MELD score, but underweight patients had an increased risk for poor outcomes. So frailty, what is it? Well, first of all, it's a broad term. It's classically used in the medical literature by geriatricians, and we've sort of taken it from their field and used it in ours. It's defined as a clinical state of decreased reserve and an ability to endure health stressors. And although this representation deviates somewhat from the classic geriatric definition of frailty as a global construct, physical frailty represents clinical manifestations of impaired muscle contractile function that are commonly reported by patients with cirrhosis. So the operational definition of frailty for patients with cirrhosis, we're talking about physical frailty, the manifestations and consequences of the loss of muscle function. And it's present in over 30% of patients listed for liver transplantation, and that's likely an underestimate. Having frailty is linked to increased waitlist mortality, decreased quality of life in patients awaiting transplant, increased hospitalizations as well. And frailty worsens longitudinally over time if we don't do anything about it, and it can persist after liver transplant as well. So even though a single patient can be described as frail, sarcopenic, which is a loss of muscle mass, so literally a deficiency of sarcomeres, to take you back to basic science, and malnourished. So even though, like I said, a single patient could be just defined as any of those, frail, sarcopenic, and malnourished, thinking about the terms separately is useful, because it's not just malnutrition, as you can see in this schematic here, that contributes to frailty. There are cirrhosis-related factors, such as synthetic dysfunction, cognitive dysfunction, and buildup of ammonia. Other systems such as metabolic dysregulation, insulin resistance, and endocrine dysfunction. There's physical inability related to muscle disuse and cardiovascular deconditioning. A lot of our patients have what's called a cirrhotic cardiomyopathy. Okay, they don't have as well-functioning hearts. And then environmental or organizational factors as well, which I'll talk about a little bit more in a bit, social determinants of health. And these are the etiologic factors that you can see at the top that lead to these manifestations of muscle dysfunction, frailty. And the outcomes are, as I mentioned already, increased risk of decompensation, healthcare utilization, a decreased health-related quality of life, death, and adverse post-transplant outcomes. So why is it so common? Well, I touched on this a little bit so far, but to go into it in a little bit more in depth. Well, first of all, malnutrition, okay? This is the impaired intake and uptake of both macronutrients and micronutrients. So zinc, folate, thiamine, vitamin D, just to name a few. So in some of our patients with chronic liver disease, it's related to reduced oral intake. So if they have an abdomen that is full of acidic fluid, they have decreased appetite, they may not be taking in these nutrients to begin with. A lot of our patients have cholestatic liver disease, where they cannot absorb, for example, fat-soluble vitamins, vitamin D being one of them. And then they have altered metabolic processes as well, including increased catabolism. Cirrhosis leads to impaired hepatic ammonia clearance, which itself, the buildup of ammonia, leads to mitochondrial oxidative dysfunction and myotoxic damage, further contributing to the acceleration of muscle loss. Systemic inflammation and endotoxemia, which can lead to increased infectious complications as well, physical inactivity in these patients, and then social determinants of health. So while we often talk to our patients about a healthy diet, say a Mediterranean diet, this would just be an example, can patients really afford all of this, and do they have access to this delicious spread? I am also realizing right now that this session is right before lunch, so I'm sorry I'm showing you this photo. Social determinants of health. Many patients with cirrhosis have a limited knowledge to begin with about their disease self-management, and that includes nutrition therapy. Inadequate food knowledge and preparation skills, and a term called food insecurity also is a significant contributing factor for these patients. So that is those are social factors such as poverty, isolation, and limited access to nutritious food. If you're telling a patient who doesn't have a reliable source of income to go to Whole Foods and shop for fresh fruits and vegetables, they're going to not be able to do those things. They're going to look at you like you're crazy. Financial strain limits caregiver presence. It limits monitoring as well, and then limited supervision for physical activity, less attentive management for cirrhosis complications, such as timely lactulose therapy. All of these are social determinants of health that contribute to this condition as well. I already mentioned earlier that frailty is strongly linked with mortality in both the ambulatory and acute care settings, as well as the post-transplant setting. The AASLD recommends in their guidelines that all patients with cirrhosis should be assessed for frailty with a standardized tool both at baseline and longitudinally. And hopefully, as we go through the remainder of this talk, we can talk about practical ways that we can all do this in our own practices. You certainly don't have to be at a liver transplant center to be able to assess frailty objectively in a patient with chronic liver disease. So frailty by the Liver Frailty Index is which I'll talk more about in a second. The Liver Frailty Index is an objective measurement of frailty. It's associated with a nearly twofold increased adjusted risk of death. And this is in a study of over 1,000 patients in the clinic awaiting liver transplant at a multi-center study in 9 transplant centers. So the Liver Frailty Index was a tool developed in San Francisco at UCSF. I think they have a great logo, by the way. Since LT also stands for liver transplant, and they managed to work a liver into the logo. But it basically includes 3 key features that can be measured in the clinic. So hand grip strength, chair stands, which assess their muscle strength, and then balance, 10 seconds each in these 3 positions, side by side, semi-tandem, and tandem. So this is assessing nutrition, muscle strength, and neuromotor coordination. So frailty, as measured by the Liver Frailty Index, improved in only 16% of over 1,000 patients with cirrhosis awaiting liver transplant. And post-liver transplant, their Liver Frailty Index scores worsened from pre-transplant values in a significant proportion of these patients. So, for example, at 3 months after liver transplant, their Liver Frailty Index score worsened in 60% of patients. Worsened in 40% of patients at 6 months and 32% of patients in 12 months. All of this is underscoring the need to optimize their frailty before transplant and then continue with those recommendations afterwards. And then only 20% of patients achieved functional robustness as defined by the Liver Frailty score less than 3.2 by 1 year after liver transplant. And I would argue that we certainly can do better than 20%. So I've alluded to this already, but the Liver Frailty Index has established cut points to define robust, pre-frail, and frail. So I won't bore you with the calculation of these numbers, but those 3 modalities that I talked about, the hand grip strength, the muscle strength testing, and the balance testing, ultimately produces a score, okay? And under 3.2, we would consider them physically robust, 3.2 to 4.3 pre-frail, and over 4.4 frail. Each 0.1 unit change in the Liver Frailty Index over 3 months is associated with a 2-fold increased risk of death, independent of MELD score, which I think is kind of a remarkable figure. And you can see the high hazard ratio there for that statistic as well. This is a test, the Liver Frailty Index, that we do at our center. We test this on all of our patients who are undergoing liver transplant evaluation, and then depending on the scenario, retest them as they go through the evaluation process leading up until liver transplant. So what can we do about this practically? Okay, well, first of all, I want to talk about practical interventions for patients who are identified as malnourished. So a big emphasis that you'll hear us talk ad nauseum about, especially when we're seeing patients in the hospital, is protein intake. So protein intake of 1.2 to 1.5 grams per kilogram per day for adults with cirrhosis is recommended. And that maintains a positive protein balance. I want to emphasize here a common misconception that protein intake to this degree does not worsen hepatic encephalopathy. Older recommendations may have hesitated in promoting high protein intake for a cirrhotic patient because of breakdown of the protein leading to increased ammonia production. That really does not happen. So does not worsen hepatic encephalopathy to promote protein intake to this degree. Prolonged fasting should also be avoided to limit that exacerbation of catabolism that I talked about earlier. And there's good evidence supporting an early morning breakfast or late evening snack in these patients to limit the time period that their body is catabolic. And then enteral supplementation should be considered. So for example, tube feeding, particularly for patients awaiting liver transplant who have failed oral supplementation. And in those patients who are critically ill, we would actually target an even higher protein target, up to 2 grams per kilogram of their ideal body weight. When patients ask, well, what am I supposed to do? How can I increase my protein intake? Well, if they have the capability and resources to do so, we often tell patients to find a protein shake that they like. And they may say, well, I've had Boost and I didn't like it. And you can say, well, there are about 20 or 30 different brands at the grocery store if you go to that aisle. And you can typically find one that you like. That you can see in some of these labels that some of them have up to 30 or more grams of protein per shake. And we encourage intake of these protein supplements. Certainly, you have to personalize their calorie needs. The energy expenditure in a patient with cirrhosis typically ranges from 28 to 38 kilocalories per kilogram per day. And so current nutrition guidelines for patients with chronic liver disease would be a caloric intake of at least 35 kilocalories per kilogram per day. How about physical activity? Well, this would be a tailored approach, certainly, per patient. So creating a physical activity plan is important. We talked about sarcopenia earlier, the loss of muscle mass. A lot of these patients are physically inactive because of how chronically ill they are. If they continue to not use their muscle, they're going to continue to lose their muscle mass and therefore their function. And I want to emphasize that that's a big deal in these patients. In these patients who cannot use their muscles anymore, they often can't walk. We sometimes see a patient who is only 40 or 50 years old with decompensated cirrhosis. They come into our clinic, they can't walk. It takes 3 people to help them to the exam table. They're in a wheelchair. Such a patient cannot survive a liver transplant. And it's important to make sure that we're intervening well before it gets to that point. It's certainly possible and common for somebody to be too sick for liver transplant. And like I said, we want to avoid that. So creating a physical activity plan is important. Combination of aerobic and resistance training for 150 minutes a week. You know, my own approach is to start by simply asking patients if they're able to walk, 15 to 30 minutes a day to start with, before you start talking about resistance training and so forth. And this is particularly important in the sarcopenic obese phenotype, which is certainly a common condition that we would see. Can also utilize modern technology, fitness trackers, smartphone apps. Again, this goes back to the social determinants of health, but if they're able to, and if they have those resources that can provide real-time objective tracking data for the patient. What can we do about social determinants of health? Well, while I'm not expecting that we can solve some of the underlying socioeconomic factors that led to these issues in the first place, we can, when we're seeing these patients in clinic, provide education to the patient as well as the caregiver about, first of all, just disease self-management. A lot of our patients, before we even get to talking about the intervention, need that education about what they can do to manage their disease at home. and that includes nutrition therapy. It's important to be clear on responsibilities in a multidisciplinary setting. And so if you have the capability or the resources to have a registered dietitian with you, to bring them in to this conversation as well. Advocate for resources for patients negatively impacted by social factors such as poverty, isolation, limited access to nutritious food. Obviously, this is a very broad recommendation, but it is something that we should be thinking about how we can use our positions to do these things. And then management of cirrhosis in terms of practical intervention. So when possible, the cause of their underlying chronic liver disease should be addressed. So just as an example, eradication of chronic hepatitis C, which I think is a almost universally accessible intervention at this point that can be done in a primary care clinic, does not require seeing a hepatologist, will reduce systemic inflammation. Alcohol-associated skeletal myopathy may be reversible with alcohol cessation. Management of hepatic encephalopathy and ascites. Certainly, the presence of ascites, as I mentioned earlier, leads to early satiety and limits their exercise capacity. So managing that with appropriate doses of diuretics, salt restriction, and paracentesis, just as examples. And liver transplantation. So I think that while we like to think that liver transplant cures the patients of all of their problems, many problems can persist, including frailty. And so trying to intervene before transplant to make sure we're improving frailty and sarcopenia is really critical. And this also emphasizes the need for pre-transplant interventions, what we might call prehab, so like rehab, to prevent or minimize frailty and for mechanisms to identify transplant patients before they become severely frail. So conclusions for today. Malnutrition and many other interrelated factors lead to a highly prevalent frail phenotype in patients with chronic liver disease. Frailty has been strongly linked with mortality in both the ambulatory and acute care settings, as well as the post-transplant setting. And clinicians should reassess malnutrition risk and frailty in patients with chronic liver disease, whether it be rescreening for the development or evaluating for worsening of these conditions. Emphasizing physical activity, nutrition, and protein intake are really the three big take-home points in terms of interventions that any of us can be doing when we're seeing these patients. I want to just mention that if you're in our community and want to reach us at any point, we do have a 24/7 attending hepatologist that can take your doc line calls. But importantly, I also included the phone number and fax for referrals, including outreach, and listed our outreach clinics there. We're going to be starting an outreach clinic in Grand Junction next month. That's my email and cell phone at the end. And though I have a question slide, and those are my daughters, and I think we all recognize the toy on the right, because we all had it, I think, when we grew up. That is not the correct way to use it. We'll take questions at the end when we do our panel talk. But I want to encourage as many questions as possible for this session. So if you think of anything, hold on to it, and we'll do that at the end, and we'll have one of our staff walking around with a microphone. So thanks for your time, and I will now introduce the next speaker. All right. Our next speaker is Dr. John Rice. John is an assistant professor of medicine here at the University of Colorado, also a transplant hepatologist. He's also my roommate in a way. We share an office. So we do see a lot of each other. Alcoholic hepatitis and liver transplant, when is transplant appropriate, is the title of his talk. I'm sure a lot of you may have questions about this. So thanks, John.
Thanks, Avash. Thank you, everyone, for being here. All right. Good morning, everyone. As Avash said, I'm John Rice, one of the transplant hepatologists here. Today, my talk is alcoholic hepatitis and liver transplant, and when is transplant appropriate? This is a hot topic in liver transplantation with significant variance amongst centers and even within our group as providers. There's significant stigma and misinformation surrounding this topic. So my goal today is to provide an objective framework for providers to approach this problem. I have no disclosures for this talk. So kind of going through my learning objectives for today, we're going to start with understanding the current problem in the United States. Next, we're going to define the types of high-risk alcohol consumption and how to screen for them. Then we're going to define alcohol-associated liver disease and alcoholic hepatitis. We'll then review how to treat alcoholic hepatitis, as well as indications and requirements for liver transplant. And finally, we'll review the University of Colorado's alcohol high-risk pathway, which some of you may have interacted with at times through referrals or seen our patients. So let's start it off with a case that we've all seen before, unfortunately common. You're in clinic and you're meeting a 28-year-old male who's referred by an ER for 1 month, progressive jaundice, edema, and abdominal swelling. He has no past medical or surgical history, no family history of liver disease, denies any new medications or supplements, denies any recreational drugs now or in the past. But he does endorse that he's been drinking about a pint of whiskey per day since losing his job at the beginning of COVID. You start by getting some labs. As you can see here, he has some macrocytic anemia with slightly low platelets and an elevated white blood cell count. His LFTs are elevated in a mixed pattern with AST greater than ALT and a mixed hyperbilirubinemia. His INR is elevated as well. Get an ultrasound, which shows an enlarged liver with a heterogeneous echotexture, nodular surface, portal vein reversal of flow with recanalization of the umbilical vein and a large spleen with some moderate ascites. Putting it all together, this presentation is consistent with alcoholic hepatitis, which we've all seen before. I know that subjectively, we've felt the rise in number of cases that have occurred since COVID, but let's look and see if there's any objective data that discusses this. So as you can see, there was a rapid rise in alcohol sales at the start of the pandemic, which has unfortunately not come down to pre-pandemic levels. There's a lot of reasons for this, including unemployment, isolation, lost loved ones, exacerbation of the mental health crisis, unrestricted or unstructured work environment, amongst many other factors. In a survey by the National Institute of Alcohol Abuse and Alcoholism, around 60% of people increased their alcohol consumption since the start of the pandemic, with only 13% decreasing. However, cirrhosis-related mortality has in fact been on the rise over the last 2 decades or so. In young people, this is almost exclusively driven by alcohol-associated liver disease. It seems that the pandemic only accelerated a growing health public emergency. The rise in alcohol-associated liver disease has correlated with a rise in transplant for alcoholic hepatitis. The graph on the left shows the rise in alcoholic hepatitis listings, and the right shows the number of deceased donor liver transplants for alcoholic hepatitis. One thing to note is that the rise does predate the pandemic as well. And this is likely because early liver transplant for alcoholic hepatitis was not a standard of care until proof of concept from a New England journal by Mathurin et al. In 2011. So this has been a rise that's been occurring for numerous reasons, but there was definitely a significant rise that occurred at the start of the pandemic, which again, we're all feeling now. But what type of drinking leads to alcoholic hepatitis as we close in on the social happy hour coming up this afternoon that I'll run for you? So here's a reminder of a standard alcohol unit looks like. Beer is a 12 ounce at 5% alcohol. So unfortunately, the 16 ounce IPA at the local brewery is more than 1 drink to your liver. Also for wine, that's a 5 ounce glass of wine. So there's about 5 glasses in a bottle of wine and about 1.5 ounces 80 proof alcohol. So as you can see, these standard units are going to be used to kind of as a framework for discussing number of units going forward. But what patterns of drinking actually lead to are actually worrisome? So here's some high-risk alcohol consumption patterns, specifically starting with binge drinking. So around 140 million people in the United States drink some amount of alcohol. Of this, around 67 million drink in a binge drinking pattern, which is defined as consuming 5 or more alcoholic drinks for males or 4 for females on any occasion. Heavy drinking, which is an important one when we're talking about liver disease related to alcohol or alcohol-associated liver disease, is having more than 4 drinks on any day or 14 in a week for male, or 3 drinks on any day or 7 in a week for female. So in general, it's thought that keeping below this amount will not lead to alcohol-associated liver disease. However, there's technically no safe amount of alcohol, and further studies are coming out looking at links to cancer and other disorders that are associated with any amount of alcohol consumption. So minimizing is important. So when do people have a problem with alcohol? So we used to call this alcoholism, but the term is now alcohol use disorder, which is meant to destigmatize and encourage providers and patients to treat as a medical diagnosis. Unfortunately, around 15 million Americans will meet the criteria for alcohol use disorder, and 1 in 3 Americans will meet this diagnosis at some point in their life. Studies have shown that around 35% of patients who have an alcohol use disorder will have some amount of alcohol-associated liver disease in their life. So as you can put the math together, that's a lot of people who have some amount of alcohol-associated liver disease. So this is a busy slide, but here are the symptoms of alcohol use disorder. There's a range of symptoms and life impacts that are meant to identify disordered use as well as tolerance and dependence. The number of symptoms defines the presence and severity of disease. So alcohol use disorder is diagnosed or defined as having at least 2 positive responses. This is then quantified as mild, moderate, and severe based on the number of symptoms. Given the number of questions, this can be obviously a time-consuming process, and that's why several shorter screening questionnaires have been created. One of the more common one is the CAGE questionnaire. So this is 4 questions. Have you ever felt like you should cut down? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And have you ever had a drink first thing in the morning? A score of 2 to 3 indicates high suspicion for alcohol use disorder. This test has a sensitivity of 75 to 95% and a specificity of 85 to 97% for detecting alcohol use disorder. And a positive test should prompt a more thorough screening. Another easy screening tool is the Audit C, which has been shown to be more sensitive than CAGE. This questionnaire quantifies how often and how much a person drinks, as well as how often they binge drink. Cutoff score for Audit C is usually 3 points for women or 4 points for men. This test has a sensitivity of 83% and a sensitivity of 90% for identifying alcohol use disorder. Again, a positive test, should lead to further evaluation and a full evaluation. So some of you might think, how does this type of alcohol consumption actually lead to liver disease? So obviously a busy slide here as well, but briefly, alcohol-associated liver disease is a spectrum, which includes steatosis, steatohepatitis, or inflammation related to it, cirrhosis, and HCC. As you can see on the left, patients move throughout this progress, sometimes in a linear, but there is potential to move back and forth if it's early in the process and caught early. So this occurs by the liver metabolizing ethanol to acetaldehyde, which leads to immune activation, glutathione depletion, lipid peroxidation, and mitochondrial damage. This leads to inflammatory response, which is further propagated by alcohol-induced gut permeability that leads to changes in gut microbiome and gut translocation. The inflammation activates fibrogenic cell types, which lead to fibrosis and eventually cirrhosis. The injurious effects of alcohol in the liver is not dose dependent, but there is a threshold beyond which risk occurs, which is usually this heavy alcohol use, which we talked about before. Progression between these different stages is very patient level. So things like genetics, sex, ethnicity, obesity, and concomitant liver disease all affect how fast you move through this. A common question is when patients come in, why do I have cirrhosis when my drinking buddies only drink, they drink twice as much as I do? And I always tell the patients it's too much alcohol for your liver. It's also a framework for discussion around alcohol use disorder as people try to minimize their use. But it's important to understand that everyone is different, and there are thresholds for everyone is different as well. I do want to note the diagram on the left, which was a green arrow between steatohepatitis and steatosis, that there is around 20 to 30% of patients who do not have cirrhosis at the time of diagnosis. I cut out a couple slides in here, but basically this is a very common question of, do I have cirrhosis or not? And it's a question that honestly at the time of diagnosis, if you have steatohepatitis, is not important because they both can lead to decompensated liver disease. This is a question to be answered later on if the patient does not recompensate with sobriety and end up in that 20 to 30% range. So while it is important long-term, in the short term, it is not necessary for treating these patients. So we're all here to kind of talk about alcoholic hepatitis for this talk. So what is it? This is an inflammatory process that requires a minimum consumption of greater than 40 grams a day for women or 60 grams for men, which is around 3 to 4 drinks per day for greater than 6 months. The onset of jaundice should be less than 8 weeks with an AST greater than ALT ratio of 1.5 and only a moderate elevation in liver enzymes less than 400. So if it's higher than this, you should think about secondary processes. You also need a bilirubin greater than 3. So we'll kind of review each of these management and outcomes. I actually cut a couple slides on nutrition, which is near and dear to my heart as well, as Dr. Kalra just talked about it. But those protein and calorie goals are evidence-based and have a mortality benefit potentially in this population as well. So early intervention is important. So one of the mainstays for treatment for alcoholic hepatitis is treatment of the underlying disease, which is alcohol use disorder. Treatment of alcohol use disorder includes both counseling and medications. I won't go into the specifics because it's definitely beyond my skill set. It requires input from a mental health provider. However, when we do require counseling for transplant, it is at minimum individual counseling and not mutual aid societies like AA. Beyond that, we commonly defer to addiction provider since there is no proven superior modality. One thing that is important to note is that patients admitted with alcoholic hepatitis, early rehab has significantly reduced the risk for hospital readmission, relapse, and even death. And so early addiction counseling is really important. It might seem trivial, but getting them involved early and getting these people into counseling, specifically inpatient counseling, has been shown to help these patients significantly. The other thing to note is that some recent studies have shown that incorporating alcohol use disorder treatment with liver care has improved outcomes as well. So these alcoholic clinics are kind of popping up, and there's a couple different models, and one of which we'll be bringing to the university at some point. So more TBD, excitement for the future. So there is a role for alcohol use disorder pharmacotherapy, despite the adverse risks events in patients with alcohol-associated liver disease and decompensated cirrhosis. So the FDA has actually approved a couple, disulfiram, naltrexone, and comprosate for alcohol use disorder. However, none of these are actually approved for advanced liver disease. The only one that's shown efficacy is baclofen, which was a single center study that needs further investigation. But if you're looking for evidence, there's the one there, but is not FDA approved. More research is needed, but I definitely strongly encourage people to not be afraid of these medications and to encourage people to ask interest in these patients or getting them into, because you'll get a lot of messages from providers who are taking care of these people in the mental health capacity. And you know, in the right setting, they can be effective, but you just have to be careful in decompensated cirrhosis. And in fact, I'd probably avoid them mostly in that population. So how do we screen for patients? Now you've gotten them into counseling, you've gotten them on medications. The phosphatidylethanol, the PEth test, is kind of a mainstay of what we do here at Colorado for monitoring these patients. So PEth is a phospholipid that's formed by reaction of phosphatidylcholine with ethanol in the red blood cell membrane. So this is why we call it the A1C for alcohol. It has a half-life of 10 to 14 days, and it will remain elevated for 2 to 4 weeks, but sometimes longer with chronic repeat heavy use. A cutoff of greater than 20 has been shown to show a high sensitivity and specificity for heavy consumption. And something that will come up, came up this last week in eval clinic, but a positive test really only comes from a blood transfusion. You can theorize that if this is on the blood, that if you get blood from someone who drinks alcohol in a heavy sense, you can have a positive test. And so that is really the only false positive, not baking with alcohol, not NyQuil, not any of those things that will come up. Really, blood transfusion is the only one. So it's really good for kind of cutting through the discussion and saying, positive, it's positive, and you kind of have to move on with that fact. But it's not meant to catch patients. I tell all my patients that this is meant to elicit a conversation. And honestly, some people will endorse use after I tell them what the test I'm going to be doing is, but some people still continue to deny, which is an ongoing problem as well for their access to transplant if needed. So what can we do medically to treat for these patients outside of treating their baseline alcohol use disorder? And so steroids, as many people know, is kind of the mainstay of what we have to offer, which is not much at times. So patients who have a MADRE discriminant function that's greater than 32 are candidates for steroids. Modern evidence comes from the STOP-AH trial, which showed a non-statistically significant decrease in 28-day mortality with prednisolone 40 milligrams daily. Further future meta-analysis, though, however, has showed some statistical significance. But one thing to note is that there is no benefit outside of the 28 days, which there's a lot of theories behind that regarding who goes back to alcohol and other reasons. But there is no significant benefit long-term. The power of this is also increased through using patients with a MELD of greater than 20 or 21 or greater. So it's important to use that in conjunction with your MADRE discriminant function when deciding on risk-benefit profile. And while this evidence is weak, I think it is okay to start steroids in patients who meet criteria. But remember that patients with infection, GI bleeding, renal dysfunction are all excluded from this study and shouldn't be contraindications to use. Another thing to remember is that people who had treatment with prednisolone there was twice the number of infections. And so remembering a low threshold to stop if that develops. But as you can see here, there's only so many options. And there's another score that we can use, which is the allele score, to decide when it's not working and we should stop harming the patient and stop the medication. So outside of the discriminant function, the allele score is the other part of this equation. It uses age, albumin, renal function, prothrombin time, serum bilirubin, as well as change in bilirubin at day 7. However, more recent analysis showed that day 4 is acceptable, which further allows me to say, let's stop this after 4 days if it's not working, so the harm is reduced. A cutoff of greater than 4.5 predicts poor prognosis and lack of response to steroids, which should prompt discontinuing. Non-responders, in fact, had a 25% 6-month survival compared to 85% for responders. So this is a big deal, not only for obviously finding medication that might be helpful, but just understanding the risk of this population for steroid non-responders. And this will kind of lead to what we'll talk about with transplant. And then, therefore, in patients who are not, as I said, therefore, patients who are not eligible or don't respond, transplant is important for discussing this. So here's kind of the crux now that we've got to the point. So these are sick patients. They have not responded to our limited standard of care. You know, who should we refer? And so given patients can potentially avoid transplant and recompensate, the goal is to defer transplant as long as possible while supporting them medically and simultaneously treating their alcohol use disorder. However, not all patients will recover. And so who should we consider early transplantation for? Since we don't have great scoring for this, we don't have great ways to predict this. So there was a consensus conference determining several criteria. They recommended considering patients who have severe steroid, refractory, or intolerant alcoholic hepatitis. These patients couldn't have any previous knowledge of their liver disease and couldn't have any concomitant substance abuse disorder. Most importantly, they needed to have a favorable psychosocial profile, which we'll review in a second, which obviously is a very nebulous term. So the big question that always comes up on our phone calls on DocLine or from in our hospital is how long should these patients be sober? So historically, we always thought about the 6-month rule. This was actually to provide time for liver function to improve and to avoid transplant. There's no evidence that 6 months reduces relapse, and it actually encourages dishonesty and does not encourage treatment for alcohol use disorder. So patients potentially would lie to say, oh, it's actually been 6 months, but it might have been sooner or may have benefited from more intensive treatment. The most important thing, I think, is that it's an unrealistic barrier for transplant. 75 to 90% of deaths occur within the first 2 months. And so it's important to identify patients that won't go back to drinking who would benefit from a transplant, given the high mortality in this population. However, since time doesn't predict relapse, what factors should? So they've looked at this and they've looked into protective and negative factors, which is a lot of things that we kind of talk about when we're in clinic or eval of what are good and bad. And our psychology and social work team help us kind of put these into categories, and we kind of have to weigh that scale together. So protective factors include insight into their addiction, social support, substitute activities for alcohol addiction, improved self-esteem or hope, and perception of negative consequences of their alcohol use. So these are all things that are protective factors. Negative factors are psychotic disorders, personality disorders, family history of alcoholism, alcohol dependence diagnosis, repeat attempts at rehab, unrelenting substance abuse despite physical and social consequences, as well as social isolations. Thinking about these are kind of used later on when we talk about our alcohol high risk pathway and how selecting patients that we try to obviously maximize protective factors and minimize negative factors. As with all things, they created a score called the SALT score. So this is used to predict relapse after transplant. It uses the quantity of consumption, failed attempts at rehab, alcohol-associated legal issues, and a history of non-THC substance abuse. And a score of less than 5 actually has a 95% negative predictive value for sustained use post-transplant. So it could be helpful. I think we don't always use the score. I haven't really heard this come up in our committee, but all these things definitely come up when discussing this. So, once we've picked a patient, so why do they actually benefit from this? So here's the landmark study for early liver transplant for severe alcoholic hepatitis. And inclusion criteria included severe alcoholic hepatitis with non-response to steroids. They required that the event was the first liver decompensation, which comes up a lot in these conversations, as well as close social support and absence of severe psychiatric disorders. This actually led to a screening of less than 2% being included for the study for transplant, so highly selected population. However, the results were remarkable that it showed a 6-month survival of 77% in those that were transplanted and only 23% if they weren't transplanted. So a significant mortality benefit with this. Another important study was the Accelerate AH trial, which is a retrospective multi-center study for early alcohol transplantation for severe alcoholic hepatitis. The median length of sobriety was only 55 days, and the median MELD was 39. So these are really sick patients. So mortality was actually 70% at 6 months if these patients weren't transplanted. So they actually found a 94% post-transplant survival at 1 year and 84% at 3 years. But I think the big question that people have in this population is not the medical. We know how to take care of transplant patients. We assume that we can take care of these patients afterwards and they will survive. The question is, do they go back to drinking? So they actually showed that only 10% at 1 year went back to, and this is a high-risk population, obviously, went back to sustained alcohol use at 1 year and 17% at 3 year with a median time of 25 months. So, not all these patients are actually going back to drinking. However, harmful excessive drinking led to 32% of these patients developing cirrhosis within 4 years. And the median time to death happened in, or two-thirds of these patients died from related to their cirrhosis, and the median time to that was 1.1 years from the diagnosis of cirrhosis. So if these patients do go back to drinking heavily, they get sick fast and can die quickly. So it is very important to treat alcohol use disorder after transplant to continue to take care of these patients to prevent relapse. So I always tell patients we're treating two things simultaneously here. I'll even joke sometimes transplant's the easy part and alcohol use disorder treatment's the hard part. But here at Colorado, we have some requirements specifically around candidates must admit their use. They must deny significant, if they deny significant use, then they don't have alcohol use disorder or they don't have insight into it. They need to demonstrate this insight and commitment to lifelong sobriety. They need a lack of coexisting major uncontrolled psychiatric disorders or other untreated addiction. They need to be able and willing to engage in the evaluation process. This does come up sometimes on our inpatient side where patients are unfortunately too confused or intubated or too sick to interact. So we can't really have a psychosocial evaluation when someone can't. Even if they have supportive family advocating for them, they have to advocate for themselves as well, unfortunately. And historically, patients were required to leave the hospital to initiate alcohol counseling and screening. However, as we saw before, a lot of these patients will die before or can't get out of the hospital. So, what are we supposed to do for those patients? This leads us to kind of the UCH alcohol high-risk pathway. And so this uses a lot of those same requirements from before, but more specifically, there's no sobriety length. So this can be done during an index admission and in the hospital. In addition to what was required for alcohol use disorder, they can't have any prior relapses, no major complications of their alcohol use disorder in general. They need the support of their advocating hepatologists, and they need unanimous agreement amongst the transplant committee. After transplant, we do monitor these people. This has been a flux recently, but they used to see a provider every month afterwards, as well as get monthly PET tests afterwards. We've backed off on the amount of us seeing them every time, but they still do really well. And in the initial cohort, I think of like 30-some patients, there was 90% sobriety at 1 year, which is kind of consistent or even better than some of the national studies. So I think this slide kind of gets to, what can you do to help these patients? I think it's clear that, these patients would benefit from transplant in the select population. But identifying patients early by screening for alcohol use disorder can prevent them from getting severe disease and requiring transplant. Get a detailed alcohol history and document the protective and negative factors that was discussed before that helps communicate with our team. Discuss alcohol use disorder like a medical diagnosis. Discuss there is no safe amount and they should quit immediately. Offer resources for addiction medicine and counseling to help get them into counseling, treatment, and medical therapy. One thing that I think comes up a lot is people say, oh, they're drinking. Why do I need to check a PET test? I think it's important to check a baseline to show trajectory if they get sick in the meantime. So check one at baseline and then monthly. And then medically start steroids in appropriate patients and only continue them when they're indicated. And I think at the bottom is kind of the key to the slide while it's hidden on the bottom. Early referral for transplant is always appropriate. I don't want anyone to feel like, oh, I'm nervous to send them too early. Send them early and let us kind of get the care they need. And if it's too early, we'll evaluate any barriers to transplant, any psychosocial problems, and get them back to you and ready for next time if they do get sicker. So I think early transplant's important and always reach out anytime. So thank you again, everyone. And obviously we can talk at the end about, any questions. Thank you.
Okay, I mentioned that Dr. Rice and I are roommates, and Dr. Wieland is our neighbor, actually, in our office, so we're a close family. The next talk is going to be focused on fatty liver disease, and I'll leave Dr. Wieland to go over the nomenclature with you. She's an associate professor of medicine in our division. She's also co-director of our multidisciplinary fatty liver clinic, and she's a Rocky Mountain Highlights course director, part of the course director alumni. She passed the torch over to me and Blake, so we appreciate her guidance as we put together this year's conference. Thanks, Amanda.
Wonderful. All right, thank you so much. And I do want to thank the new bright and shiny course directors that have set up a wonderful conference. I love the new location. It's convenient for me, which should always be the goal of everything. So welcome. Thank you guys again so much for inviting me to come. And I have been tasked today with talking about what used to be called non-alcoholic fatty liver disease, or NASH. So it's 2023. What can we offer for the treatment of NASH? And now, MASH. Very exciting. Were you guys aware that the name had changed? Is that new to you? All right. Well, that is the late breaking new news of fatty liver disease, is that we changed the name. No disclosures. So educational goals today. We're going to review the definitions in the new nomenclature of metabolic dysfunction associated steatotic liver disease, or MASLD. Just rolls off the tongue, formerly known as NAFLD. We're going to discuss the spectrum of metabolic liver disease, and including MASH, the more concerning form, with inflammation and fibrosis. We're going to review the guidance for screening for high-risk patients with MASH with fibrosis, and then we're going to outline some treatment strategies. What do we do in 2023? All right, so the new nomenclature. So I'm still unsure. One thing, I'm probably going to say it wrong about 50% of the time during this talk today, and I probably have not updated all of my slides. So you can go to the ASLD website and see a lot of very excited hepatologists talking about this new nomenclature. So the big punchline, so steatotic liver disease, which used to be called fatty liver disease. So we've removed the word fat and moved to steatosis. So the idea is that that broad umbrella term of steatotic liver disease, it used to just be alcohol and non-alcohol. So defining the majority of what was going on by what it wasn't didn't make a ton of sense. It stigmatized to some of the patients when they really, weren't drinking. So it added barriers. So in trying to get a better idea of the spectrum of what causes steatosis in the liver, you can see that they've got several different categories now. We've just heard all about alcohol-related liver disease and how that leads to steatosis. There's also these kind of NOS causes there, and cryptogenic. But we're going to be really focusing today on the metabolic side of things. You can see they also have this category of MET-ALD, which is basically metabolic disease and alcohol on a spectrum. But again, we're going to be focusing today on metabolic dysfunction associated steatotic liver disease, or MASLD. So I'll probably refer to it as metabolic liver disease just because that's too many words for me. So again, we got fatty liver disease is now steatotic liver disease. Non-alcoholic fatty liver disease, or NAFLD, is now metabolic dysfunction associated steatotic liver disease, or MASLD. Say that 10 times fast. And non-alcoholic steatohepatitis, or NASH, is now metabolic dysfunction associated steatohepatitis, or MASH. So why is MASLD important? You guys are probably very aware that there is a lot of fatty liver disease out there. It is the most common cause of abnormal liver tastes in the Western world. There's high risk in those with metabolic dysfunction, thus the name. Obviously, diabetes, obesity, insulin resistance, all of those risk factors. Up to a third, if not more, of our population is affected by metabolic dysfunction and the liver ramifications. 1 in 5 of those with metabolic fatty liver can have NASH or MASH. See, you guys can count every time I mess it up. 1 in 25 of those can progress to significant liver issues, including fibrosis and cirrhosis. So big deal. And it really is MASH, not just the steatosis, is associated with this increased mortality. So the spectrum, to get an idea of what we're talking about. So, at the heart of this, there's fat accumulating in the liver. And that's really just bland steatosis. And that's what most people, when we see fat in the liver, have. But the subset has the fat leads to inflammation. So it's toxic fat, leads to inflammation. That inflammation, which technically has to be defined histologically or with a biopsy, but it's crazy to biopsy millions of people. So we have to use all these other markers to assess for that. And so that is the diagnosis of MASH, where you have fat inflammation that can lead to scarring. And that's what can eventually lead to cirrhosis and liver ramifications. So the amount of scarring is on a spectrum, anywhere from 0 being no scarring up to 4 being advanced scarring or cirrhosis. So blue is bad. I couldn't give a talk about the liver without pictures of liver biopsies, because that is why I'm a hepatologist. I think they're very pretty. I think these should be framed as art, although unfortunately the prettiest ones are often the worst involved. So MASH with fibrosis, again, is what's really associated with higher mortality. You can see they're all-cause mortality. So you got on the bottom line there, 0 up to 4. So that's moving towards cirrhosis, just all-cause mortality. A lot of this is actually cardiovascular disease and all those other metabolic issues. And then you can see liver-related mortality. Liver decompensations, cancer really escalates and jumps off at stage 3 and stage 4. So that's what we really need to find from the liver side, although everything along the spectrum is important for the health. So getting into the meat of it, how are we going to approach MASH in 2023? So it's a massive problem. So number one, we got to find these high-risk patients. We got to stop ignoring it. I think that's actually been something that's happened over many years now, that it's really recognized and finding these high-risk patients. So we want to screen for fibrosis. That's really the heart of that. The second thing is we want to treat these high-risk patients. And it really comes down to weight loss. Weight loss is key in these patients. And whether that's through, the heart of it is going to be lifestyle, really talking with our patients about that. A lot of this is just counseling and motivating. You need to motivate them and destigmatize it and really kind of empower them. You know, considering bariatric surgery is really important. And then all these new tools. There's a whole other talk that can be done on new pharmacologic treatments for weight loss. And I'm sure you guys have heard of semaglutide, the new kid on the block, and all of the GLP-1s. And I'll be mentioning those throughout this talk as well, because they are really important in this area of metabolic dysfunction. So diabetes management is really moving towards endocrinologists have really embraced that when outcomes of the patient is really how they should pick their diabetes medicines. And so for MASH and MASL, they really need to pick agents that treat that underlying issue. And so we'll highlight that as well. And then I'll also touch on some future therapies that are going to target MASH itself and try to actually get to the core of that. We still are lacking in that area. So let's talk about identifying these high-risk patients. So the AGA came up with this really nice screening pathway to find the fibrosis. So this is really targeted for those that are on the front lines of caring for patients. So it's going to be primary care docs, endocrinologists, GI, obesity specialists. So how do they think about this in their busy day? So in general, it's a step-by-step process. You want to identify those at risk. So it's going to be people with metabolic risk factors. It's going to be diabetics, those with incidental steatosis, mild elevated liver tests. They need to think about it. Then very basic, simple history and labs, and then calculate these non-invasive scores. And then that puts them in these risk buckets and really kind of organizing it into these buckets where you can follow the patients and get them to the right places is really what's key. So we're going to run through this quickly with a patient. So this is a 45-year-old Hispanic female. She's referred, noted to have abnormal liver chemistry tests. So you can see there she's enriched in all the metabolic issues, elevated BMI, diabetes, hypertension, has a family history of her mother with cirrhosis. And so you can see her labs have the kind of mild hepatocellular injury. Platelets are a little on the lower side, but nothing that really on itself would be that striking. Imaging shows a steatotic liver, but otherwise no signs of portal hypertension or advanced liver disease. So what are we going to do next? So going to our handy algorithm, we would want to calculate this non-invasive test. And the take home is the FIB4, cheap, easily, readily available. There's other proprietary tests out there, but really at the heart of it, to make this easy and simple and to just get this on the radar and find these higher risk patients, FIB4 is the way to go. So FIB4, 4 values. I love things that are simple: AST, ALT, age, and platelets. And then with that, you get low risk, intermediate, and high risk. You can see I just found a quick and easy calculator on the internet, and this patient ended up having a FIB4 of 1.64. And so that puts her in intermediate risk group. Of note, if you guys are using Epic at the university, you can just do .fib4 and it calculates it for you. And you can just put it in your note. It's quite beautiful. It didn't work for a long time, but now it does. So that's quite nice as well. So getting back to our pathway. So we have our high risk patient. And then she's got that intermediate FIB4. And so the next step there is to do a liver stiffness measurement. So what is liver stiffness measurement? So this is what is called vibration-controlled transient elastography, is the most widely available, also known as FibroScan. And so this is the report you get from a FibroScan. Basically, a FibroScan is a form of an ultrasound, more or less, that's specialized, where you just put the probe on the side and they get a little liver tap, and it sends a vibration through the liver, and that vibration gives you an idea of the density. So this actually gives you a physical measure of the stiffness of the liver. And the key number we look at is that E score, or elasticity score, or the KPA. And so back to our nifty algorithm, you can see that the liver stiffness measurement here, hers of the 17 puts her above 12, which is in a high risk group. The other number to remember here is anything above 8 kind of falls into that intermediate or high risk group and requires a little bit more digging in general. So again, steatosis, FIB4, intermediate, high risk. So she is sent to hepatology. So what hepatologists do, we biopsy. And I will say the decision to biopsy or not, is really case by case. We in general favor a lot of non-invasive things, but in this young patient, there was some other factors going on. It seemed very important to get a really solid baseline to know her degree of fibrosis. And so she did have biopsy confirmed steatohepatitis, and she was had been confirmed that she really had no alcohol. And so that would be MASH. And the fibrosis level was also found to be in this advanced stage 2 to 3 out of 4. So what do we do now for this lady? And this is really where things are in evolution. So what are we going to do for this young woman? So again, the cornerstone of all of this is lifestyle changes. And it's important. It takes time, but this across the whole spectrum, again, really empowering patients. And, I really try to keep it very broad, and again, just try to, it's that fine balance where these are often people that have struggled with weight. It's part of the metabolic dysfunction. And so you want to give credence to that it's really hard, but then they also need to realize that a lot of it is on them. It's not fair, but they need to learn to really how they can work with the metabolic dysfunction. So weight loss is the key for the majority of these patients. And even this weight loss of the 5 to 10% really has meaningful improvements in histology. Maintaining that is hard. So the goal is really to have these long-term healthy habits that they can stick with, and exercise as part of that to maintain that weight is also really critical and important. So other things to consider: bariatric surgery is a very good tool for certain patients that have really failed to maintain weight and have other barriers. And in general, the indications are the same as for the obesity in general. It hasn't been shown to be specifically a treatment for NASH and fibrosis, but we do know that after bariatric surgery with successful weight loss, a very large percentage will have reversal of fibrosis. So it really can be a great tool. One caveat with bariatric surgery is if they have advanced fibrosis and cirrhosis, it can be okay in selective centers with experience, but as soon as they have portal hypertension, it's contraindicated. So now pharmacologic treatment options is another thing to think about. This is an area, again, that's expanding, and really there's so much to develop in this. And I think this is the new wave of really changes in healthcare. You guys, I'm sure, have all heard about Ozempic and its role. So these pharmacologic weight loss options really can have benefit in a lot of patients. So using those tools and getting patients to, obesity management specialists, empowering PCPs to get comfortable with weight loss medicines, these are all important tools. And my role as hepatologist is really letting them know that they should consider these for you. I don't think most hepatologists or gastroenterologists are going to embrace being the prescribers of these. Some selectively might, but it really is getting it back on the ones who are managing the metabolic disorder. So, and again, for diabetics, really picking the medicines that have efficacy in MASH is really essential too. There are no FDA medications for MASH itself, but there are clinical trials ongoing, and we'll talk about some of those as well. So this is, again, back to that AGA. They have a really nice summary here, just kind of when you put your patients in the buckets, what does that mean for how you're going to manage them and what can we do? And things to highlight here, again, as I said, lifestyle across the board important. Weight loss, yes. They have some caveats about how aggressive to be about weight loss there across that spectrum. Pharmacotherapy for NASH, you can see that, yes, the interesting thing there is that we don't have any. So I think it's funny they have that on there, but I'm going to mention a couple that are in the ASLD guidelines, but when those get approved one day, which I'm cautiously very optimistic, there is a need, especially in these intermediate and high risk group. That's why we got to find them now. Diabetes care. This is something to me that I talk with my patients about. So diabetes care, the majority of it's done in the primary care setting. Endocrinologists, I think, are a little more aware of this, but really empowering PCPs, if they can, to think of these other agents. Even if they're controlled on metformin, that might not be the best med for them. Metformin has never been shown to be helpful in NASH and fatty liver. So seeing if they can get them a GLP-1 or even pioglitazone in certain cases, which is kind of a old school and not used as much, but does seem to have some benefits in diabetics with fatty liver. So really mentioning that to patients and saying, talk with your PCP about that is something I always try to do as well, that there might be better agents for them based on their risk factors. So we're talking about for MASH specifically, again, nothing approved now. A couple things that we'll touch on today: vitamin E, the data on pioglitazone, and a little bit on the GLP-1s and a couple other things on the radar. So when we talk about the AASLD guidelines, do have some caveats about a couple things with vitamin E and pioglitazone. So vitamin E was studied, it's getting old now, 2010, so that's been a while, 13 years ago, when it was a very well done study, the Pivens trial, and they looked at vitamin E. And overall, vitamin E did show improvements in the NAFLD activity. So it more or less resolved NASH and the inflammation, but didn't improve fibrosis. So it really didn't catch on. It was only studied in non-diabetics, non-cirrhotics. So the caveat is if you have somebody with biopsy-proven MASH and they've got active steatohepatitis and they have some fibrosis, this is something to consider. There are some risks with it. It has some all-cause mortality that's not well understood, but overall fairly low. Prostate cancer risk seems to be real. So a family history of prostate cancer in male patients, you want to talk about the risk benefits. But I have a few patients that I'll mention, you can try vitamin E. The dosing was 800 in the studies. Some people favor just giving the 400 as something to try. So it's something to consider. And there's some newer studies that were a little bit flawed in that they were retrospective, but they showed that patients on vitamin E had decreased need for transplant. And so it can be considered in some patients. I don't like it as this idea of, just take vitamin E and don't do the lifestyle thing. So it's all about making sure that they're doing the lifestyle things as well. And pioglitazone. So PPAR gamma, so an older medication. So in general, again, this in these older studies and trials clearly improved inflammation, but didn't improve fibrosis. The big issue with pioglitazone was that it increased weight. And so with that being a side effect with it, it really fell out of favor. Although when you look at the weight, it's actually that the weight goes from being the visceral bad fat to more the peripheral fat. So it can be an option as part of their diabetes regimen. So it's something to mention again that if they're on pioglitazone or considering that for some patients, it's dirt cheap too, which can be a good thing in our healthcare system as well. So, but that weight gain has really always made it one that is not as favored. So in general, these are the ones that are mentioned in the AASLD guidelines and can be considered in these very selective subgroups, but pretty limited in the true efficacy, especially if somebody has more advanced fibrosis or cirrhosis, so we need something better. So this is meant to be a busy slide because it's showing that it's busy. There's a lot going on out there as far as clinical trials for fatty liver disease, multiple agents under investigation across that whole spectrum, phase 1, 2, 3. And this is like a billions of dollar market out there. So there's no lack of work going in. Unfortunately, due to the complexity of the pathophysiology of metabolic dysfunction, there's so many targets to hit that over and over again, we see things just aren't meeting the clinical outcomes. And so there's a lot of X's on here. I know it's hard to see because it's so little, but basically as soon as something's looking good, it really doesn't come to fruition. The most recent one to fall is obeticholic acid. Unfortunately, really, in the end, the FDA just did not think the data was robust enough despite a couple submissions to the FDA. So that's also been halted as a phase 3. So this is a little bit simpler, but still busy of currently ongoing phase 2 and 3 investigations. And this changes so quickly. I've highlighted ones here that are under currently ongoing at the university. So it's very dynamic which trials we have coming and going. So we're always open to hearing about interested patients, motivated patients. So always send them our way. But these are some that we have right now. I'm going to highlight a couple real quickly just about the phase 2 that has shown some promise in these, including saroglitazar and then semaglutide, GLP-1. So saroglitazar, so this is a PPAR, but it's an alpha gamma agonist. And so depending on which receptors the PPARs act against, there's different side effect profiles and benefits. So the alpha gamma is positive as far as steatosis and insulin resistance, so it's very promising. The phase 2 trial showed a lot of positives as far as improved liver tests, decreased liver fat, insulin resistance, and it had a very positive atherogenic dyslipidemia. So it was very positive in a lot of factors, and it was safe and well tolerated. This is actually approved in India as a treatment for NASH. So this is something, or MASH, and right now the phase 3 trial is enrolling and ongoing. So New England Journal came out with the placebo-controlled trial for semaglutide, so GLP-1. So again, phase 2 trial, very promising in the, this was fibrosis 1, 2, and 3. The primary endpoint of this was resolution of the inflammation, the MASH, and no worsening of fibrosis. And it met that primary endpoint. You can see there the higher dose there had 59% that had resolution of the inflammation compared to 70% placebo. Of note, that B box over there, it did not show significant improvement in fibrosis. So I think that's really the limitation of semaglutide. And in general, that's the issue, is that we're not seeing both inflammation and fibrosis improve with one agent. That's probably because there's such a so many mechanisms going into this. The separate study that was done in cirrhotic patients was a negative study. It really didn't show any benefits, probably because fibrosis is the driver. So this gets to this issue of this new idea that's coming out of combination therapy. And so this is where you synergize and optimize these histologic benefits. And so you can think about it as if you have somebody with non-cirrhotic NASH, you need to target the inflammation and maybe some anti-fibrotic. But if you've got these patients with cirrhosis, then you really need an anti-fibrotic potential and the inflammation. So it probably depends on where they are in their disease and using more than one agent. So right now, the phase 2 study going on for the GLP-1 semaglutide in combination with FXR and an ACC inhibitor is ongoing. That the phase 2 was found to be safe and effective, and the phase 3 trial is ongoing, and we're enrolling this at university. So conclusions. So how to approach NAFLD in 2023. Or MASLD, dang it. So you identify MASH with significant fibrosis. So remember, FIB4 greater than 1.3, liver stiffness measurement greater than 8, following that very nice algorithm. We need more aggressive monitoring and management in primary care, referral of these higher risk patients to the tertiary teams, educate the patients, really stress, empower them, multidisciplinary approach to weight loss, have the PCPs and endocrinologists target their diabetes regimens, and then consider clinical trials and await these novel agents. Thank you very much. Okay. Thank you.
Have a seat. Have a seat. Yes. All right. We're going to start off our panel discussion, first of all, inviting Dr. Rice and Dr. Wieland to stay on stage. So before we go into sort of the pre-prepared poll everywhere questions, just wanted to open it up to the audience to see if any of you had questions for any of the three of us to start with. And Lindsay has a microphone here that she can bring to you. So raise your hand if you would like. No worries if you also would not like. We'll keep an eye out. We'll go into some of the questions. For those of you who were not here earlier, if you would like to be involved in participating in the question, you can connect to the QR code at the top, or you can also, probably the easiest way is to send a text that's CU-HEPGI to the number 22333. All right, so generally, what is an appropriate protein intake goal for a cirrhotic patient identified as frail? Obviously, this is going back to my talk from earlier. And as the answers come in, it looks like the majority of you are correct. The answer is 1.2 to 1.5 grams per kilogram per day. The other two options are too low for most patients, and I'm glad that no one picked D. So you heard the soapbox comment earlier that protein intake does not worsen hepatic encephalopathy, so good job. All right, just more of a fun question. I told you it was a fun fact, but see if you remember. Dr. Thomas Starzl performed the world's first successful liver transplant. In his youth, he had planned on becoming a teacher, a priest, a mechanic, or a dentist. Huh? Yeah, exactly. All right. So yes, it was he intended on becoming a priest, but fortunately for the three of us on stage, he did not do that. All right. And true or false? There are current and recently updated AASLD guidelines that review assessment of and interventions for frailty and malnutrition. So if I forget absolutely everything from this talk after the happy hour today, I can consult those guidelines anytime I please, since they are available for free and can access by simply Googling frailty guidelines cirrhosis. And of course, that is true. So please use these guidelines as well. And again, please raise your hand if you have any questions for us at any point. So how long should patients be required to be sober prior to listing for liver transplant? A, no delay. B, greater than a month. C, greater than 6 months. D, greater than a year. Dr. Rice?
So this is meant to be just as a discussion point that I think no delay is the requirement in certain patients, but longer is better. So I think the question gets to more counseling, more time of sobriety is important and actually a goal of ours. But it doesn't mean you shouldn't call us if a patient is interested in being sober and meets those criteria for our high-risk pathway. So no delay versus longer the better, but requirement should be at no delay, and give us a call if they're interested.
John, you earlier talked about post-transplant alcohol use, and it may have been surprising for some people in the room to see 10% at 1 year returning to sustained alcohol use, 17 to 20% at 3 years. When you would hope that those numbers would be as low as possible. Should that number be 0? Is that even a reasonable goal?
I think in general, it's an unreasonable goal, but to have 0. And I think in general, we've seen that 90% at our center and thought we're actually probably being too strict. Because if you understand the natural history of the alcohol use disorder portion of the disease, a certain amount of patients are going to go back to drinking. I think it's almost flipping the coin where we should start talking about risk mitigation after transplant rather than complete sobriety in these patients. And how do we keep them from drinking too much? But any amount of alcohol, though, is bad for the liver, and that's the goal and the request and requirement. But that's not like we should stop taking care of them afterwards. But yeah.
Should steroids? Oh, sorry. I think we have a question. Okay, we'll get the microphone over to you. Should steroids be used to treat patients with alcoholic hepatitis? A, yes. B, no. C, what about pentoxifylline? It's answering a question with a question. And I know that was allowed. D, I need more information.
So yeah, I think this question is kind of getting at the crux of a lot of the consults and things that we get to is I think both A and D are the answer. I think, yes, it can be used for alcoholic hepatitis, and yes, you need more information. I think there's a lot of tools to help us minimize the amount of exposure to these patients and to help them. And no, you should not use pentoxifylline for those thinking that in their head.
Question.
Hi, my name is Sarah. I'm a dietitian, and we're dietitians. We work in the GI clinic. Just curious, Dr. Wieland, within the NASH population or MASH, sorry, that yes, we talk about weight loss and supporting them because it is so hard, but I think there's a lack of that integrating us into those programs. And so, is that something that I guess specifically at UC Health that's been considered, and maybe nationwide, is that something you're seeing within those programs as well?
Yeah, so I would agree that access to dietitians, there seems to be a lot of barriers that shouldn't be there. I even struggle when I'm seeing them because it depends on their motivation, what they're willing to do, how engaged they are, and then what their insurance will cover. And I find I've tried to predict it and then I can't. I think they would all benefit from seeing dietitians because even if they think they're eating healthy, there's clearly improvements that can be made. So yeah, why they can't be integrated better. I think it's a systems issue is a big part of it. I think it's the patient, the systems, and then probably the providers. We don't even know exactly how to get them in there. here at the university, what I usually do is I'll kind of give them my general. As you know, it's a lot of work to really get a good, it takes a lot of time. So I just kind of skim the surface. We have our multidisciplinary fatty liver clinic, which is basically me and Tom Jensen, who's an endocrinologist, and he digs deeper. I focus more on the liver side of things. But we would love to be able to also have a dietitian at that. It wasn't logistically possible in the end when we were trying to set things up. But we'll often refer to the wellness center as another access to dietitians. But I think it's a lot of systems issue is what it comes down to. And other ways to better integrate dietitians. We need more dietitians.
Yeah. And I guess I would just for here, and if you're like in your clinic or like, we kind of need your support for that and you advocating for that, because us saying, well, we'd love to be here, but they're going to probably listen to you guys more than us.
Yeah, it is. There's like levels where we fight. We have the transplant dietitians. We have pretty good access there, but even they're stretched them and what they need. And a lot of it was kind of this fight to try to get dietitian support and their time supported. But I think it came down to how the billing comes out. So I think it came down to the money.
Makes sense.
But yeah, I agree from a patient standpoint. Nutrition and lifestyle counseling and resources for that are undervalued by our healthcare system, mainly from the monetary side.
I agree. Yeah. Thanks.
Okay. Any other questions right now? We're almost done with the morning session. We are, for the sake of time, going to do one final poll everywhere question. So a 52-year-old male with a history of diabetes and obesity with BMI of 42, labs show an AST of 42, ALT of 30, platelets of 189, and a FIB4 of 2.11. What would be the next step in management? A, refer for liver transplantation. B, imaging with ultrasound. C, refer for a liver stiffness measurement non-invasively. That's with the FibroScan or vibration-controlled transient elastography, or prescribe semaglutide.
Yeah, no, good job. There is no exact answer here. I led you guys to what I think is probably the most appropriate for the algorithm that you guys have selected of the FibroScan. Ultrasound is very reasonable, especially with the slight elevation in liver tests. So you can help you, especially with his platelets on the lower side, see if he has a cirrhotic appearing liver, splenomegaly. So very reasonable to do that. From the kind of primary care and workflow, at minimum, getting the FibroScan would be a really good way to triage this guy and see, because he definitely is at risk to have more fibrosis than you would realize from just initial assessment. So, and it would be nice to get him semaglutide likely, but the reality of actually getting that approved and prescribed and access to it, you'd need more information to see if it's possible. But he actually could be a very good candidate for semaglutide.
Awesome.
Now, can I ask a question?
Of course.
Order of ultrasound and FibroScan or simultaneously ordered? Do you have a way that you approach if you're trying to, I guess it depends on the clinical situation.
Yeah,
but
I think it would depend on, I think, if this person was seeing hepatology, I would get an ultrasound as part of it. So it'd be kind of simultaneously get both of those. I think in the primary care realm, I'd understand if they didn't. It wouldn't be like first on their radar, but I think most of the time it is done and that's appropriate. So, but I think that goes to this idea of thinking about fibrosis, thinking about looking for fatty liver, because those liver tests and things at face value aren't that exciting and would get overlooked, but this guy could easily have cirrhosis and it's not being recognized. So, and I think the best way to detect that would be the FibroScan. So I think of things happening to get him put in the right bucket, the FibroScan is probably the most useful. But in the full workup, and he would probably get sent to hepatology and we would do an ultrasound. So.
And to add to that, I think we all hear from patients sometimes, well, how did no one knew I had cirrhosis before? My liver tests were normal or near normal. So underscoring that point, certainly. All right. Well, before you all run out of the room for lunch, give me 30 seconds to go over some housekeeping items. First of all, thank you to all of you for a great morning session. And thank you to our speakers as well. If we could give them a round of applause again. I want to thank our sponsors as well. This conference, Rocky Mountain Highlights, this is the 10th year, and Blake and I are really, really fortunate to be the course directors. But the reality is this wouldn't be possible without the generous support of our sponsors. The free registration wouldn't be possible without the support of our sponsors. And so I want to thank them all again by name. And as you get lunch after this, please interact with them. Our sponsors again, AbbVie Incorporated, Bristol Myers Squibb, Castle Biosciences, Cook Medical, Irby USA, Exelixis, Gilead Sciences, Intercept, Interscope, Janssen, Medtronic, Olympus, Ovesco, Sanofi, Steris, Takeda, and Fujifilm. So thank you again to our sponsors. Please visit them during the lunch break in the exhibit hall that's right outside the conference room. Again, as a reminder, if you visit 8 or more booths and get a star put on your bingo card, you will be eligible to win one of 10 $100 gift cards. To be eligible to win, like I said, you have to not only bring your bingo card to the exhibitors, but you will be giving out those gift cards at 3:30 this afternoon. That's after our debate. And I want to just close the morning session by saying that I think our afternoon session is going to be really exciting. We have several talks themed at therapeutic endoscopy. We'll then have a reception on the rooftop. We're not getting an afternoon thunderstorm at that time. We've triple checked, so it'll be safe. You can call it a happy hour if you'd like, despite what we've talked about for the last couple of hours. We're really looking forward to that event. After that, Dr. Jones and Dr. Patel are going to have a really fun debate about colorectal cancer screening. So it'll be a bit of a different format than a lecture type talk. So thank you again. Enjoy lunch, meet the exhibitors, and come up and chat with us if you'd like as well. Thanks.